Hello, everybody. Welcome to Endoscopy Talks. I'm Christopher Chamness with Carl Stortz, and I'd like to thank you for joining us on behalf of Colorado State University's new Translational Medicine Institute. Today, we are joined by Dr. Lorenzo Crosta, who serves as the director of the Avian, Reptile, and Exotic Pet Hospital at the University of Sydney. Prior to moving to Australia, Lorenzo spent many years as an avian practitioner and consultant for zoos and bird collections in his homeland, Italy, as well as in Spain, Portugal, Brazil, and Mexico. He also spent 13 years as the veterinary director at Loro Parque in Spain, which is the largest parrot collection in the world. His certifications, awards, and publications are too numerous to mention here, but most recently in 2019, Lorenzo was the recipient of the prestigious TJ Lefebvre Avian Practitioner of the Year Award. And with that, it is my great pleasure to introduce my friend, Lorenzo Crosta.
Good morning. Well, what time is there now?
Depends, who knows?
Yeah, because it's complicated what we do here, and especially when we do it, when it's related to work with somebody that is across the pond. So it is a little bit tricky, the thing. So I think we should start at this point. What do you say? So I can share the screen, I guess. Today I will try to give a general overview of what we do with birds, talking about endoscopy, and I really believe it's fascinating because this idea that God created birds for endoscopy is something that I always said, and I really believe it. I really believe that they are so ideal as patients for several reasons that we will go through now, and it's just easy. It's sometimes too easy to make a cilioscopy in a bird and understand what is going on inside. You need experience, obviously, to determine if what you're looking at is normal or is not. But that technique itself is so facilitated by the anatomical feature of the bird class. Generally speaking, that is, I believe, is amazing. First, a couple of notes about what you need. You don't need much. I mean, if you really want to look at a bird inside, whatever you want to do, the standard endoscope, or the only one for some practitioner, is an endoscope that is 2.7 millimeters diameter with 30 degrees offset, and the generally used is 18 to 19 centimeters long. Even if for making the normal observational stuff, I prefer a shorter one, like 12 centimeters, which is a little bit more stable and easier to use, and I use the longer one for procedures and surgery. With an endoscope of this size, I've been, well, if I look at the number, I'm impressed sometimes, because I've been doing 2,000 endoscopies in birds a year for 30 years. So I'm talking about roughly 60,000, including the very simple procedures like sexing a bird, but it's a big number. So I've been making endoscopy on birds that were like 12 grams up to 12 kilos with such an equipment. Obviously, nowadays, companies like Stortz, that I thank you a lot, and I've been knowing Chris for many, many years, and there is no other company that is supporting the veterinary class for what endoscopy is concerned. So a big thank to them for doing this. But they have a wonderful endoscope that is 1.9 millimeters. So if my clients or my patient would be basically below 200 grams, I would still prefer to use the 1.9, which is thinner and is better for the patient, I believe. So what we're looking at is something like 30 degrees. Do you see my arrow here on the screen if I move it?
Yes.
Okay, good. So basically, this is my homeland. It's not Australia, it's the Alps, the Italian Alps. When you're watching with something which is 0 degrees, you're watching exactly in front of you, but at 30 degrees is slightly displaced. So this allows you for working in a situation in which you can rotate on the long axis the endoscope and have a wider view. Not only if you need to make a one access procedure and, for instance, biopsy an organ, your instrument will appear in this place, and this would not be possible with a 30 degrees. But to be more proficient, you don't just want to watch inside the bird and tell something, because you will not remember. You cannot share the images with clients. You cannot share the images or the video with colleagues that might give their opinion, for instance. And in this case, so I really recommend that you have something a little bit better. So the endoscope is good, but you need something where you want to record the things that you're doing, taking images, and save it on your files. This is what I've been using for the last many, many years, because I'm a registered zoo veterinarian. So the fact that I've been working with birds mostly is because I've been working in zoos that were generally large avian collections. But when you're traveling, when you have to move your equipment, if you're based in one single clinic, obviously you want a tower with everything that you need to work with. But in a case that you are a traveling man, like I've been for many, many years, these really save your life. And sometimes in a zoo settings, you really need an endoscope that you can transport to another location within the same zoo, and this is just perfect. Obviously, the very first idea of avian endoscopy started in the 70s, I think, maybe late 70s, when there were the first publication about determine the sex of a bird via endoscopy, which is still very valid as a system. I don't see this idea as a sort of alternative to DNA sexing. Are two different things, because DNA sexing is yes and no, white and black, or boy and girl and nothing else. Hypothetically, if you take a cat that has been desexed and you test him by genetics, he's still a male or he's still a girl, but obviously he's not very usable for reproduction. So my recommendation is use the DNA sexing if you want for pet birds, but whatever it is, including any animal that has a value as a possible breeder, should be undergo a general cilioscopy examination to see if that bird is a good bird for your purposes. And you can see things even in very young birds. So you can have access to the coelomic cavity of a bird that is a, I don't know, 5 months Amazon, and you spot things that will tell you, this is not a bird you want to keep in your collection as a breeding bird. So must be, pass me the term, utilized for something different, but not for breeding. So there is a very, very different idea behind the scenes when you're talking about DNA sexing versus endoscopic sexing. First thing is we have something that can be not surgical, like looking into the nose or the choana of a bird is something that we do on a regular basis. You can imagine that in some birds, you can widely open the beak and watch the choanas. In some other, you cannot. And in any species, you can get into the choana unless you have an endoscope. So there is not one single way to do it. I prefer to approach the bird in this way, but there is not one way. It's just the way that works for you, and it depends a lot on the species and the anatomy of the specific anatomy of the beak of the animal. Obviously, the birds have a lot of complicated nasal sinuses, and in this case, you can really see how they are transilluminated by the endoscope in this blue and gold macaw. And they can be very different. This is an owl. So I'm accessing the choana of a barn owl. You want to look at symmetry, presence of exudates, inflammation, these kind of things. And this is a pigeon, so it's totally different. It's very narrow. You have difficulty in getting in, but in this case, the diagnosis is easily done. And there is also a friend coming here. You can see it on this side. So I don't think that there are no doubt about why this pigeon was sneezing. And this is a picture that I find very interesting. Obviously, this is an old picture and this is a newer one. So the instruments I was using were very different 20 years ago. But This is a good representation of two choanae, of two species that belonged until some years ago to the same genus. They were both Ara. And now some of the small macaws got into the genus Primolius, but still they are macaws. And look how different is the nasal anatomy of these two animals. Still they are macaws, but they are very different. So this is just to say that we have almost 10,000 different species of birds, and they are different. Don't give for granted that what you see in these species will be the same in these species. Can be, but can be surprisingly different. The further step after you look at the nose can be the trachea, and normally the trachea is easily spotted in and examining birds with some limitation. For instance, toucans have a trachea that is making an angle, so you don't want to use the endoscope, or you can only see the first part, and minor bird as well. And there are some other differences. Generally speaking, the trachea of bird is built on closed trachean ring, so it's easy, it's always open. So you normally go down, see the syrinx, and come back. One of the problems that you have to be quick, unless you have to work on the trachea, for which you might eventually deliver the anesthesia through the air sacs. But the tracheal observation, given that you have the animal with a face mask and being anesthetized, you have to be pretty quick when you go down in the trachea, have a look, understand if everything is normal, and come back. There are some differences, obviously. This is a penguin trachea, and penguins, most of the species of penguins, there are, I think, 18 different species of penguins. Most of them have this trachea that is divided in two, longitudinal by the septum. And you have to take it in care, you have to know it before, because you might eventually traumatize the septum when you are either using the endoscope or eventually also intubating them. This is another easy diagnosis in a crane. I think that there are no doubts about it. It's interesting. This is pretty old, but is obviously a gapeworm is Syngamus trachea. And it's interesting because you can also see the boy and the girl in this video. I'm pretty sure we have. Yeah, there is a big female, I think it's this one. And you know that this specific worm has the one strange behavior. I mean, they're impermanent copulation. So you see that there is a small male attached to the female and the large female. So I find these worms very nice. They look a little bit like the sugar sticks of Mary Poppins to me, with this red and white, but it's a very easy diagnosis. And then the treatment will be consequent. But this makes a difference between, I believe it is a Syngamus infestation, or I know what it is. And this is fascinating. And you can also show the clients, they will really jump when they see something like this. Given that we are now watching at what is not surgical, our observation of the respiratory system without any surgical access stops here, and we might go into the gastrointestinal. Most avian species, but not them all, have a crop, which is a dilatation of the esophagus. And a croposcopy is not a real term, but I coined it, is one of the maneuvers that is very common, and you need air to dilate the crop. So you normally need there are some devices like the new telepack that you've seen in the beginning, this compound, this little computer that gives you everything you need for making an endoscopy, has also a built-in air pump, which is very useful in this case, and you want to look at the crop. It's pretty easy, and also in this case, there is not a specific way to do it. It depends on the species and how you are used to do. Some practitioners hold the birds and literally lift them by the head. Somebody keeps them belly up, somebody keeps them belly down. It depends on what you want to look at and how we are used to do it. To me, the important thing is it's not dangerous to the animal, and you achieve the result that you need to. Normally, you get into the oral cavity and down the esophagus, and slowly you give a little bit of air to dilate it so that the esophagus walls will not collapse, and you just dilate it until you can inspect the esophagus and the crop itself. Sometimes there is some food or water, so you want to aspirate it before you do your job. It's absolutely necessary. The bird will be intubated, obviously, but still, if there is a lot of water, can be dangerous for the animal, and not only, it might be prevented in your good observation of the crop. You go down with the endoscope very, very slowly, deliver air as much as you need, and you will dilate it and inspect it. You might want to retrieve foreign bodies. You might want to take cytology samples. You are not taking from the crop biopsies with the endoscope because the wall is too thin and you might easily perforate it. So you eventually go for normal surgery. From the crop, you go into the stomachs. So you go into the, from the crop, you access normally the thoracic esophagus, and from there, the subsequent will be the proventriculus and the ventriculus. In some species, you can easily reach the ventriculus, in some not, because I'm talking about rigid endoscopy now, and in this case, you would like to have a flexible one, but still with the rigid, you can access most of the stomach of the normal species. And what you normally do is you go in the crop, dilate the crop, well, if the bird has a crop, we will see an owl, for instance, they don't have a crop, so it's very easy. It's a straight tube that goes from the mouth to the stomach, and it's very easy to do it. But in some birds, like pigeons, like parrots, like falcons, there is a pretty big crop, so you have to identify the entrance or the passage from the crop to the esophagus, and this is tricky. There is a point that I call the rose, and because it looks like a flower, there is all this, the mucosal folds come together, they congregate, and there is something which looks a little bit like a flower, like this, and there is the place they want to dilate and open the crop. So this is a pigeon. It's a real case, had these big seeds in the crop, and they looked at X-rays exactly like stones, so we wanted to identify. And this that you see here is what I call the rose. You will see it better now because I'm cleaning the endoscope against the crop wall, which is a normal procedure. And you see this. This is the spot you want to look at. Once you spot it, it's very easy. You dilate it a little bit with air. And here we are in the thoracic esophagus, in the proventriculus, and in the ventriculus. So you see, it's a very easy maneuver. You must pay attention. The only thing you really want to look at is don't use too much air. Some people that are not very used to do that tend to deliver too much air, which is dangerous for the animal, so you don't want to do it. But once you understand that you just deliver what you need, it's a very easy maneuver. It's even easier when you go in birds that don't have a crop, like this owl. You see the peristaltic movements of the esophagus, and passing into the proventriculus is direct. You almost don't perceive it. Here we are. So it's a straight channel, a straight tube, a straight pipe that goes from the mouth down. So it's pretty easy to reach it. And we are in the stomach, obviously, and this is, to give you an idea of the magnification, this is the food of a day-old chick that the barn owl ate the day before. So this gives you an idea of the details that you can observe. And what you want to look at is, like in any other species, ulcers, blood, like in this case, there was something wrong here. And you can make a tangential biopsy of this structure. It's not easy. I've done several times. As I said, I would not do it in the crop, but when it's proventriculus and ventriculus, is something that you can really do. And then, oh my God. And then we have a cloacoscopy. As you know, birds don't have two openings. They only have one. Imagine the cloaca like a sort of a bell. The first chamber of that is divided in three chambers. The first chamber of the bell is called coprodium. And it literally in Greek means the room of the feces. Then there is a small fold that separates the coprodume from the urodume, that is the room of the urine. And then there is a proctodume, which is the last part that is almost inapparent. It's difficult to differentiate. In any case, it's cup, C-U-P, and it's very easy to do. The cloaca you want to dilate as well, but you don't dilate it with air. You dilate it with warm saline solution, which make your life easier. It gives a sort of aquarium effect that makes your visualization so much better. And you can see really interesting details. This is same species. So this is a blue and gold macaw. This is a normal cloacal wall. And these are some small puntiform hemorrhage. And this can be a disease in some case, is a symptom, or sometimes can be due to the fact that, like in this case, that bird had a cloacoscopy done the day before. So this is a mild inflammation due to the process we done the day before. This is an inflammation of the cloacal wall, so it's a cloacitis, but here is normal cloacal wall, and you can see that here you start seeing the intestinal villi. And actually, in the different species, the disposition, the anatomical disposition of the entrance of the rectum can vary a lot. But what you see is that still in the cloaca, there will be some changes in the mucosa. And this is the typical rectal mucosa in a macaw. This is also nice. This is a Illiger macaw where you see the urinary papilla. The urinary papilla is interesting because you can see it. And when there is a flux of urates coming out, you see that the urates is not soluble. So this kind of creamy thing is coming out from the urinary papilla. And some drops of this white stuff, in most cases, will help you to identify the spot. So this is a pigeon. This is the urinary papilla, and it's the right one. This is the left urinary papilla. This is obviously urates. And these are the genital openings. This is a boy. And it's something unique. It's not easy to see them. But look at the quality of the image. Again, thank you, Storz, for providing us these unbelievable instruments. Okay, and this is also something that I find fascinating. This is a macaw. And if you look at the video now, you will see that I'm just pressing a little bit, create a little bit of pressure on the cloacal wall. And you can see the single red blood cells running in the very tiny vessels, which is amazing, I would say. This is also very interesting. I don't know if there are many people that do work with birds normally, but everybody knows about the papillomatous disease of parrots, which is normally a disease that is linked to a herpes viral infection in mostly South American parrots. So it's a herpes. It's something interesting because is important is there is some link with the Pacheco disease, and you don't get rid of it. I mean, herpes is like a diamond, is forever. So when we look at this video, you see it's a cockatoo, and we know that cockatoo have different infections. This is a papilloma caused by a different virus. And the interesting fact is that also the anatomic presentation is different. Most of the South American parrots with an issue with papillomas are presented with something that pops out of the vent, like a sort of reddish cauliflower or a wart. But cockatoos have papillomas that are really internal in the cloaca. And in this case, it's very close to the opening of the rectum, as you can see it. So we've done for the first part that is not surgical, Do you have any questions? Is there anybody who has some doubts about what I've been talking about?
I think we do have a couple of questions, Lorenzo. First of all, with all these procedures, I think in most cases you're using a 2.7 millimeter scope, like you mentioned, which is maybe
Correct.
the worst, right?
Correct.
But what are the limitations of it? When would you go to a different scope, rigid or flexible? What would be the most common scopes outside of that for these kinds of patients?
So generally speaking, if I have a larger bird and I want to go gastro, I prefer to use a 4 millimeter flexible in this case. And now when I say larger, I refer sometimes also to cockatoos, large cockatoos, because they have a very long neck. And so sometimes it is impossible to reach the stomach, the proventriculus and the ventriculus with a normal rigid endoscope because it's too short.
Mm-hmm.
So either you make a cut into the crop of the bird, bypass the head and the neck and get from the crop directly into the stomach with a rigid, or you get a long flexible endoscope, which is very good. So cranes, storks, penguins, and eventually if I need large cockatoos, I would prefer to use a flexible when it's time to go into the stomach. And okay, when it's a very tiny burst, nowadays, when it's below 100 grams and I have to do a cilioscopy, normally use a 1.9.
Okay.
Obviously, the 1.9 is fascinating.
Yeah. Below what size?
Pardon me?
Below what size, you said? Below
100 grams.
100 grams, okay.
Yeah. I mean, 100-gram bird.
Mm-hmm.
But with the 2.7, I've done birds that were below 20 grams. There was not a thing like a 1.9 in the beginning. So we were forced to, it's safe if you know where your job is not difficult, but obviously if I have something smaller, I prefer it.
Okay. Next question. Foreign bodies, do you see many? And what are the most common kinds of foreign bodies you see, if you see them?
I've seen several. I've seen several. For instance, we had here a chicken that ate a screw and it became immediately the screwed chicken. It was very funny. We have a very nice video about it. The most common in my life have been feeding tubes for artificial feeding. Mm-hmm. And some people are so silly that use short tubes. I always tell them, use a long tube. If it detaches from the syringe, it's still there, you just take it out of the mouth. If it is 4 centimeters, it goes into the crop in 1 second, and in 2 seconds, it is already in the stomach. But since it's normally silicone or rubber, it's very easy to grab and then take them out. It's not a difficult procedure. The difficult things are the tiny objects, like for instance, we had one girl that one day brought a macaw that ate a piercing. So it was very tiny, and the macaw had eaten a lot of different stupid stuff. I could find it only because it was shining with my light. So I saw something shining and I thought, must be that, and almost blindly I got it, but it was very challenging.
Yeah. Okay, I do have one more, Lorenzo.
Yeah.
What is the risk of filling up the coelom via the oviduct with saline during cloacoscopy? For example, when you're investigating a problematic egg retention.
Yeah, I've seen it. To be sincere, I've seen it luckily only during our practical labs when you use dead pigeons. So I've seen this happening. I can imagine this happening in birds that are laying. I can really imagine this happening because you can dilate the oviduct. I don't have a video now in this presentation. It's out. It's something a little bit more advanced, but you can easily get into the oviduct when the bird has just laid or is ready to lay and dilate it with water. So you must be very careful. You don't want to have a flux of water getting in, but just few drops, enough to dilate the organ so you can see it. Not only, you always keep the bird like 30 degrees up, with the head up.
Yeah. Okay.
Yeah. This
Great.
is one thing that you really need to do when you're going into the cloaca, and especially in the oviduct with the water, with the fluid. Yeah.
Great. Okay, that's it for now, Lorenzo.
So now we go into the cilioscopy, or to say into the internal cavity of a bird. I remind you that birds don't have two separate cavities. They don't have a diaphragm. So we only have one that includes the thoracic and the abdominal cavity. So this fact make it very easy for us to work. I mean, you don't need to insufflate like you would do in a mammal. You don't need to provide air or CO2 inside the body cavity. Everything is already dilated. You just have to know the anatomy and have to know what is normal or not. But the general distribution of the organs in birds is the same. Obviously, the single organs might look a lot different, but generally speaking, they are always located in the same place. So it's not very difficult. Cilioscopy is the queen of the techniques that we use in birds, obviously. As I said, there is nothing like a bird that is just perfect for doing it. It is amazing. So normally we have several possible accesses to the coelom of a bird, but the most typical ones are four. The left lateral, that is still the most widely used. Right lateral, that basically is used if you have a specific lesion on the right side or to examine the pancreas. Ventral midline, that is normally for liver and the tip of the heart. And paracervical, which is for the trachea, the primary bronchi, the thyroid gland, if you can see them, and the upper part of the heart. Generally speaking, how we do it, it's pretty easy. You keep the bird in this position. You might put something to keep the leg forward or not. So you want the left side. I prefer to have the legs that are free, and I will hold them with my thumb, that I find it more flexible as a system. And it's very easy, because if you look in a closer look, you have the lower part, the abdominal side of the semimembranous muscle, and the last rib. Where they meet, just behind it, is your entry point. And it's the same in any species. It's pretty easy to identify. So you make a small cut, a vertical cut, like 2-3 millimeters, no more. Then you might want to use a very small mosquito forceps, if it is a large bird like a macaw, or a very small and sharp Edson forceps in a, I don't know, Amazon. Even in a lovebird, you want to use an Edson because it's smaller. And at that point, you only need to introduce the endoscope. I normally introduce it in a vertical way, and then I turn left to get into the caudal thoracic air sac, which is my, how to say, main room for my plaza, my square, from where I would move around and I can come back in the place that is the central place where I can redirect my endoscope from. So I open with the Edson, introduce the endoscope that I normally hold in this way, and with 2 fingers at this point to balance it. To give you an idea, what we can see from the left lateral approach is base of the left lung, air sacs, heart, liver, spleen, proventriculus, ventriculus, intestinal loops, kidneys, ureter, adrenal gland, left testicle, and the left ovary. So this is a general overview of what we can see inside the abdomen. There are some writings that you can understand. This is the left testicle. In the white cockatoo, it's normal to have a black testicle. This is the left adrenal gland. This is the left ureter, the rectum, and it goes into the cloaca here, exactly here, enters into the cloaca, some intestinal loops, the wall of the ventriculus and the proventriculus, again, the middle and the caudal lobes of the left kidney, and then we are in the abdominal sac, and we go into the caudal thoracic. This is the base of the left lung, the primary bronchus that I can eventually climb and get into the lung. And in some species, I can almost go to the axilla, we will see it, and the heart. I'm in the cranial thoracic air sac now. Here we see the liver and the ventricular wall. There is also a paracervical access and a parasternal. So the paracervical, this is a very tiny dove from South America. The bird is belly up. These are the pectoral muscles. And as you can see, here we have the trachea and one primary bronchus and the base of the heart. This is something very easy to achieve, but the only difficult thing, I would say, obviously you must be very careful because you're playing close to the heart. But in the end, what is a little bit more difficult is when you have access to this area, not to perforate the crop, you have to dissect the skin, identify the crop, put the crop aside and get in without breaking the crop, because this is not, well, the crop you can still suture, but you don't want to do it. We go into the repro. This was the start of everything, I would say. So sex determination was the very first thing we needed to do in birth to say if it is Mary or Peter. So most of the, I would say almost every single avian species is only developing the left ovary. So you want to go left, and there are several organs that you can see, and also the species that are very few that eventually develop the right side as a feminine specimen will also develop the left one. So no point, if you need to see the gonads, you go left. So this is difference, is a blue and gold macaw. You see the kidney here and the testicles. Here we have the adrenal gland, the two testicles. You can see this as an adult bird that is not in breeding season, and this is during the breeding season. They don't have this huge difference like some passerine species in which the testicle can increase like 300 times. But actually, you can see how more vascular and bigger it becomes. This is something which is pathologic. These small warts are actually sort of part of the germinative epithelium of the testicle that pops out. So the bird is not fertile in this moment, but is not a chronic orchitis. I know it because I biopsied a lot of those. I was spotting this lesion very frequently, and I know what it is now, but it's something that you might easily encounter. And this is an adult African gray girl. Look how nice blossoming is this ovary. This is a young one. This is a Vasa parrot from Madagascar. So we have the adrenal gland here. We have the ovary that is starting a little bit of development, the cranial pole of the left kidney, and the oviduct with the ovaric ligament here. Don't misunderstand this, because some males, especially when they are young, might retain this ligament. And there are some colleagues that sex the bird, they can't, maybe there is an intestinal loop here, and they see the ligament and they say, girl, is not correct. Use your endoscope to move down the intestinal loops and you will see the real organ. This is what you want to see. This is also something that is very interesting. This is a young girl, not well developed, and this is an old one. I'm always asking people, do you see the difference? Because I don't see any difference. I cannot tell if this is blossoming or it's simply shrinking, and also this one. The ovary is not enough to tell you, generally speaking, there are obviously some exceptions, but generally speaking, the ovary itself is not enough to assess the age or the maturation of a girl, unless you know the age, because if it is 2 years, you know, it cannot be this one. And if it is 30 years, cannot be this one. But in any case, what you would want to look at is the oviduct. The oviduct will tell. So you see the ovary, you know, you don't know if the bird is maturing or is going back to be inactive because it's too old. This is an immature oviduct. This is a mature oviduct that I define virgin. This oviduct, you see, this is the mesometrium that is still visible, is the ligament of the oviduct, and this oviduct is mature, but no eggs have been passing through it, or maybe one or two, but no more. And this is a used oviduct where several eggs have been passing. So I refer to the quality of the bird watching both the ovary and the oviduct, and this is very important in my eyes. This is what I was speaking about before. Most of the hawks, differently from falcons, will have left and right ovary. The right ovary is not functioning, is not delivering any eggs, but still you can see that it is has a small development. So it's not abnormal that you see it in some species. Do we have any questions at this point?
The first one is sort of an aside. You live in Australia now, Lorenzo. Somebody's asking, what's the largest bird you've ever scoped down under?
Down under, I think, was a wedge-tailed eagle.
Okay. No emus?
Actually, I've done some ostriches and some emus and some rheas as well, but not here.
Okay.
Not here, yeah.
Okay. What is the general anesthetic protocol for most of these types of procedures?
Well, depends on what you want to do. If it is a, I have a nice talk about avian anesthesia, and one of the first slide is the general perspective of most clinicians is avian anesthesia is isoflurane, 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 and eventually a little bit of isoflurane.
There you go.
But if it is something very quick, like just have a look into the stomach or have a look into the coelomic cavity without the need to proceed with any specific procedure like biopsy or removing a granuloma or something like this, I normally go for a simple isoflurane easily. If it is the case that I need to do something more advanced and can be painful for the bird, there are different options depending on the species, but in most cases, we use medetomidine and ketamine. Mm-hmm. But the protocol can vary a lot. I mean, I remember we were making some good experiments with falcons back in Italy, or not experiments. We had some information from the Dubai Falcon Hospital about how to make a good premedication with medetomidine and ketamine in falcons. And actually, Antonio Di Somma, who is the head vet, told me, you use this only in falcons. And I thought that was very smart. And I did the same in eagle owls. Nothing happened, but they slept 24 hours. Like little angels, but nothing happened. And it was tricky to explain the owner why they needed to stay in the hospital for the whole day. So it was interesting. So don't give for granted that what works in a species works also in another one. But generally speaking, medetomidine and ketamine are good. There are some protocols using butorphanol as well that I like. I normally don't use very much buprenorphine because there are some indications that in some species it doesn't work because they don't have the receptors. So this is my idea.
Okay, here's a really good one. I could answer this one myself. This person missed the beginning of your talk and has a basic question. How do you achieve pneumoperitoneum in birds?
You don't need to. It's physiological in birds. They are already inflated because of the air sac system. Basically, if there is something that is different between birds and mammals is the respiratory apparatus. So very quickly, how it works, so you can understand. If you're talking about mammals, our lungs are like sponges, okay? So when they automatically inflate and will suck air in a bag that is the pleura. Imagine that the birds have a lung that is like a heater, okay? So it's rigid, doesn't expand too much. If you want to have air going through this system, at the end of the system, you attach some bellows, okay? So the air sacs are the bellows. When the bellows inflate, they will suck air through the lung into the air sacs, and when they deflate, the air will go again through the system and pass through the air, through the lung again. So basically the birds breathe twice, when the air goes in and when it goes out, which is very efficient if you're flying and you need all the possible oxygen, because it's a very aerobic exercise. And this is why it's so easy for us, because we have already air bags inside the body cavity. And not only the high pressure that it delivers to the organs make it very difficult to have a hemorrhagia. For instance, when you take a kidney biopsy or a liver biopsy, it's very unusual that they bleed too much, because it is already stopped by the high pressure inside the body cavity.
This is why they were made for endoscopy.
Exactly.
One more question here, Lorenzo. How do you perforate or enter from one air sac into another through the air sacs gently while you're maneuvering within the coelomic?
Yeah. So the typical situation would be this. If I enter in the correct way, I am in the caudal thoracic air sac. So I have something that you can imagine a little bit like a cone. You enter into the apex of the cone, and the end of the cone, the base is the lung, okay? So I measure the distance from my entry point and the base of the cone at roughly at 1/3. I simply turn my endoscope right and break through. And I am, with my endoscope, is sharp enough to go through the air sacs, and I open them with the endoscope itself. Is that clear?
That is perfectly clear. And do you close your cilioscopy incisions?
I don't. I don't, unless it is a major surgery that requires a bigger cut. I don't for two reasons. In my experience, I have never had a bird that went for the wound when it was not stitched up, but a lot of birds did touch the stitches, so I preferred to avoid it. But if you think to the anatomy of a bird and how you pull the leg, you're making a cut into one layer, which is the skin, another cut into the muscles, and then you have access to the inner organs. At that point, when the bird stands up again, the three layers are sliding one over the other. So in the end, you have a 2 mm cut into the skin that I normally just put a drop of tissue glue and that's it. Okay. Or nothing sometimes.
Yeah. Okay, we are good for now, Lorenzo.
Okay, so the last part, respiratory system. I'm talking about the respiratory system from down. So we are going here to see the lungs and the air sacs. Obviously, as I said before, when you have access to the bird's coelomic cavity, generally you have already accessed the respiratory system because you are in the caudal thoracic air sac. So this is all what you want to do. So to give an idea, this is a normal lung of a lovebird. So you see a very tiny bird, roughly 40, 45 grams. And this is the opening of the primary bronchus, which is the channel that brings the air from the tube that brings the air from the trachea to the big, more functional bellow that is the caudal thoracic air sac. So this is two examples of acute pneumonia in an owl and in a lovebird. You see how different it is from the other one. And these are two examples of chronic pneumonia. These are typical cases in which, especially the chronic one, you want to take a biopsy to understand what is going on. This is a blue and gold macaw with a chronic pneumonia. You see that everything seems to be detached from the base of the lung. And look how difficult it is for these muscles, these respiratory muscles, to do their job. They're really forced. Also, the air sac is really trying to work. There is also pericarditis, as you can see. So this is what we defined a pneumonia and also a generalized aerosacculitis. So from there, and it's very easy, and this is a goose, you can get into the lung to explore it to see if there is something wrong. And in animals that are this size, but even a little bit smaller, you can really climb the lung. And I'm using a rigid endoscope. if you know where to go, you can approach the axilla and see sometimes the nerves that are going into the axilla and then into the wing. And I'm again into my airsec, which is my starting point. It is the center of the town. This is also something that you will see when you're doing endoscopy in the respiratory apparatus. This is a typical diagnosis with this little fur. This is aspergilloma that you might want to biopsy and eventually culture or make a cytology on it, but this is a definitive diagnosis. I don't know what kind of fungus it is, but it is a fungus. I know, very likely aspergillus, but I know it is because we did the biopsy, but the looking is so typical that it's unmistakable. Liver, you can see the liver in 2-3 different ways. The most typical would be when you are in the abdominal air sac and you slide over the dorsal wall of the proventriculus, and you have to get in a space that is not existing, is between the 2 layers of the medial layer of the caudal thoracic air sac and the lateral layer of the abdominal air sac. Then you find the real peritoneal cavity, and there is what you find the liver. So you see there are 2 layers, one is here and one would be here. This is the proventriculus and this is a fatty liver. This is also the liver from the same place as the case of hepatitis. Sometimes you need to have a different approach. You might want to go ventral, and you can also see the very tip of the heart, and we will see it now. So obviously we've seen that there is not a diaphragm. So once you are in the caudal thoracic air sac and you turn right instead of left, you turn right and down, you will see the heart. But if you want to do something on the heart, for instance, the only way to make a pericardiocentesis is that you approach the very tip of the heart, and you can only do it with a medial sternal approach. This is from the left side. You see the ribs, the heart, and the liver. I remember to you that the heart of the birds is not within the lungs, but it is within the liver lobes, at least for a big amount. And this is the parasternal access that I was speaking about. So the bird is belly up. This is the sternum. This is the liver. And you have to move the liver lobes a little bit with your endoscope. This is rigid, so it's easy to do. And here you see the very tip of the heart. And this is the only place the only chance in a bird, because the heart is very protected by the keel bone, is the only way that you have to perform a pericardiocentesis if you need to. Spleen is also an organ that is very important because you might have some diseases that require a spleen biopsy. And I've done several, like psittacosis, for instance. You might have some exam done on the spleen, or leukosis. I've seen geese with leukosis in which we needed to make a spleen biopsy. The problem is that the spleen is different in shape and size according to the pathologic status and the avian species as well. But generally speaking, it is in a channel that is formed by the stomach on the proventriculus on the left side and the kidney on the right side. So once you spot the kidney and you go ventral, normally you find the spleen. Like in this case. Obviously, it's different because, for instance, parrots have a very rounded spleen, while pigeons and passerines have an elongated one. These are 3 different spleens in different species. So we have an Amazon, we have a raven, and we have a macaw. This is a spleen of a bird that is, this spleen is reacting, so you need to understand why. Also, this is something very common. This is the ovary. This is the spleen. And what is this? On the wall of the proventriculus, this is an accessory spleen, which is a fair common finding in birds. And finally, we get to the pancreas, which is tricky because remember that avian pancreas is divided in two big lobes, or a big and a small one. The small one is the splenic lobe, is behind the spleen, and is very difficult to access it endoscopically, almost impossible. And it carries almost entirely endocrinic activity, while the duodenal lobe of the pancreas, which is embedded within the duodenal loop, is almost entirely exocrine activity. So it depends on what you want to know or what is the disease they refer to. You might be able to take a biopsy of the pancreas, which is something that is normally done. So it's tricky because you have to go left. You go right. So a right access is something that is unusual in birds, and you really have to dig caudally within the intestinal loops until you find it. Once you know how to recognize this, is easy. So this is in a macaw from the right side, and you will see it's pretty easy to see this is duodenum and this is the pancreas. So it's unmistakable. It's very easy to see, but sometimes it's not easy to find it. You really need to dig within the intestinal loops, and you can lift it and take a biopsy from the border, from the margin if you want. On the other side, sometimes we have birds in which, due to the high intestinal movement or a hyperperistalsis, the duodenal loop is displaced on the left side, and you can see the pancreas from the left. This is the case. It's a juvenile girl. You see how they move. This is impressive, and obviously this is the pancreas. So, but it's not common to see a pancreas from the left. So I think we are done, and in time. I'm impressed by myself.
Unbelievable.
Yeah, being Italian and having been living 6 years in Spain, I think being in time is unbelievable.
Okay, now we're going to go over time with a few more questions, Lorenzo. Thank you. That was a great overview. First question, do you have problems with hemorrhage during procedures? I know you don't too often, but if so, how do you handle them? How much?
I didn't understand.
Hemorrhage.
What procedures?
Do you have problems with bleeding, hemorrhage?
Yeah. Obviously, I have some good videos about it. Normally, what I do is, if I do something that I presume will be at risk of having a severe bleeding, I normally have my endoscope. I use a different technique. I normally have a double access, and with the handler of the operating surgical scissors or clamps, whatever it is, I connect them to my radiosurgical unit, to the Hellman with a cable, and I can simply cauterize it. This is what I normally do. I'm prepared to that.
Yeah. Okay. And instrumentation for taking biopsy. How do you typically take biopsies, cilioscopically? Is it through the sheath? Is it?
Okay. You should know that this is what we in Italian call as violinata. As violinata is I playing the violin in front of the Storz company, because he's almost the only one who helped us in this. But any company can give you an endoscope and you can use it. You can also buy a Chinese, very cheap endoscope, and you will see the Chinese shadows. It's very good, but it's not good enough for doing most of the things. But the big difference is that the company like Storz is not only providing you a first class endoscope, it's also providing you little tools that you don't find anywhere else. And you can work with them within a bird or a lizard coelom, and it's fascinating. To date, if you want to do something easy like a biopsy, you just need a working channel. Instead of using the normal observation trocar, you have something which is ovalized. We didn't speak about it within this introductory talk because we might want to do something eventually more advanced, or somebody else will speak about it. But you have something which is oval. So once the endoscope is in place, there is still room for a small instrument which is flexible to run through the same trocar. And you see, since you're working with a 30 degrees device, you can see what you are doing. It means that within one single access, you make only one hole in the body cavity of the bird, and you can easily cut, take biopsies, remove granulomas. It's something that you can do with one only access, because the minimum you have is a biopsy forceps, grasping forceps, semi-rigid scissors, a loop, and eventually a little basket. And they all can go through your 2.7 endoscope. So you have all you need.
Mm-hmm. Mm-hmm. Okay. Is it possible to evaluate the ears?
Yes, I didn't go. Yeah, we do it all the time, but it's something that is very similar to what you would do with a normal otoscope. So I didn't put it now today, but it's a very common procedure. Obviously, we don't do it because birds don't have ears. You don't know it? No, I'm kidding. But obviously, you can see the ear, and it's very good. Have you ever seen a ear of a bird? No. In ostriches, you really see them. In ostriches, you see them because they are naked. But yeah, we do a lot. But it's something that I didn't think it was very important to put on these things. It's good. I love to do it when I believe there is something that I want to show to the client, because one of the great advantages of using an endoscope as a diagnostic tool is that itself is creating work for you. I make an example. They bring me with this crane, and normally it is a breeder or a zoo, and they have been trying everything, like, especially, you know that the most common disease of bird is Baytril deficiency. So they tried to give Baytril, they tried to give itraconazole, whatever, and it didn't work, obviously. So you make an endoscopy and you say, okay, there is this. These are worms. We have to treat them. And not only, you have to come back and I have to do a different procedure because I want to get rid of the worms that are in the trachea, and then you treat it. So you have a double rebound. You make your diagnosis, and with the same technique, you make your treatment.
Yeah. Yeah. So another question, a good general question in terms of these diagnoses. Before endoscopy, do you always perform other diagnostic exams such as x-rays, or are there conditions where you decide immediately to go for endoscopy?
Well, in most cases, I do something else. Endoscopy, well, being a bird, it might be done in the same session, or to say, I examine the client, I presume that there is something I want to go deeper in, I make the x-rays, or Petra, my ultrasonographer, says, okay, I make an ultrasound, Lorenzo, you really need to make an endoscopy. So there is a clear indication. Sometimes is like gasping. So I know that ultrasound or x-rays will not give us much. So I will normally go directly into the trachea and have a look. Or if there's something in the bleeding from the cloaca, the next step is a cloacoscopy, to give you an example. But when it's cilioscopy, normally is a second step.
Okay, okay.
Good.
Can the endoscope spread infection from one air sac to another?
Obviously, yes. Obviously, yes. Potentially, but I mean, birds are so intimate. Every organ is packed up in this little place that normally they spread already by themselves. Yeah, if you give them a hand, it's not good, but I would recommend that if you get into an air sac and you see that there is something very bad, you stop there, take your sample, send it to the lab, understand what it is before you go digging into other organs.
Mhm. Have you known any reports of ventriculus rupture because of gastroscopic procedures? And can you be
Oh,
more?
it happened. It
Yeah.
happened to me a couple of times.
Okay.
It happened to me a couple of times accidentally because we needed to do a cilioscopy for diagnostic need in very young psittacine birds, like, I don't know, a 25 days Moluccan cockatoo. So the proventriculus can be so big and so soft that accidentally, when I got in, not with the endoscope, I presume, with the Edson, I perforated it. So and it's something that I've seen a couple of times, and you understand because you get into with the endoscope and you see like grate or seeds or something like this, which is not, you should not, and you immediately know that there is something wrong. So in both cases, I was lucky. I was pretty frank with the owner. I said, listen, this happened and we can do it. So you go immediately into surgery, make a normal ciliotomy, suture back the stomach, the proventriculus, which is not very difficult, clean everything, and luckily we didn't have any subsequent serious consequences, but can hypothetically happen. Not hypothetically, it happened to me twice, I think.
Out of many endoscopies.
Out of 60,000, so it's a low number.
That's not a very high rate.
Yeah, also I must say that unless you are directly involved in bird breeding, or you are making your offering your service to a big zoo or a big bird collection, you will not have very young birds to endoscope. So it's even less unlikely. It doesn't happen in adult bird. Oh, obviously, if there is a case of PDD, you might accidentally do it, but normally it's something you don't want to do. Yeah. You don't do a cilioscopy in a bird with PDD.
Right. Lorenzo, what is the smallest bird in which you have ever used an endoscope?
I think one of the smallest was Aymara parakeets are very small. Then that comes from the Andes, and Arfaki lorikeets. They are very small, like less than 20 grams.
With a 1.9 scope?
With a 2.7.
With a 2.7?
Yeah,
okay.
Yeah.
Okay.
I did it, I remember I did it in the Loro Park, and we didn't have a 1.9 in those ages. So I've done several of those.
Okay, okay. That accessory spleen you showed us, is that common in all or most birds?
I've seen several. I would say I wouldn't say common, but you find them time by time. It's not unusual.
Not uncommon. Okay. Last question. Any advice or tips on cilioscopy in penguins?
Well, I would make a big difference. If it is a Gen 2 penguin, can be tricky because they're really fat. Really fat. But there is this myth that penguins are difficult because they're fat. I've done kings, I've done Gen 2s, and all the genus Spheniscus that look very similar, like the jackass, the Humboldt, all those animals are very easy, are just like any other bird. Is absolutely feasible. Absolutely feasible.
Yeah.
And the good thing is that penguins are very easy patients with anesthesia. So
yeah,
no worry. Don't worry, do it. Unless it's a Gen 2, especially in some seasons, they can be very fat. I would be careful. But I think that the worst scenario is that you get in and you don't see anything, just fat. Yeah. But I never had an accident. And in the second difficult is the king, because it can be fat and it's big, but it's not as fat as Gen 2s, and all the others are just like any other bird. A little bit fatter, but not. I've seen Amazons that were much worse.
Great.
Okay.
Lorenzo, thank you for this fascinating overview.
I think you enjoyed it. It was a pleasure. It was a pleasure, sincerely. It was a pleasure for several reasons. One is that it's more than 30 years I do endoscopy and I still love it. So I love to speak about it. And because I think I feel so much supported by the company that this man works for that I have to do it, because Storz has been so nice to me that I need to do something nice for them.
Well, thank you. Thank you very much.
My
I'd
pleasure.
I'd like to thank all of you in the audience for joining us. It was a nice big crowd. We appreciate your joining us. Next week, we'll hear from a world-renowned feline specialist from the UK, Elise Robertson. She will be addressing rigid endoscopy in cats, with an emphasis on presenting to the beginner a scope that has the versatility to be used in a variety of organ systems in the cat, including respiratory, urogenital, auditory, and others. That's next Wednesday, October 7th at 2 p.m. New York time. And remember, any past talks can be viewed free online at endoscopytalks.com. I'd like to wish you all well in your practices and, of course, the best of health at this difficult time. Look forward to seeing you next week. Thank you.